As is customary, we'll do some very brief opening notes. We are going to largely skip introductions in the service of bringing enough time for the didactic and great case discussion. Again, thanks to Dr. Carlson for presenting on managing geriatric depression and demotivation, and thank you to Julie for bringing a congruent case. If you would be so kind as to enter any names of people who may be joining you from your site, if it's more than just you. Also remembering to mute your microphone when not speaking, and please do feel free to say your name when you unmute. Continue to get to know each other. If you're able and have the capacity to do so, it'd be great to have your video on. We'd love to see your wonderful faces. We also do our best and have appreciated Julie's efforts to protect PHI as we talk about cases. So making sure that we're not saying or depicting anything that might reveal identities of patients or family members. A reminder that if you have to duck out early or if you come in late, our sessions are always recorded, available on the website. There's no password or sign up or anything like that. Allison will be sending out the 1-minute post-session survey in the last couple of minutes of our session today. The opportunity to fill it out now instead of doing so time afterwards. Here's the list of didactics for the rest of this calendar year. We have begun thinking about next year. So next session, we'll have a wonderful presentation on fall prevention, all the way through diet at the end of the year by our own Angela Hansen. And I would welcome, if not encourage you, if you have ideas about things you would like to see for didactics, please throw those in the chat too. Always happy to consider. Even better if you know somebody who would be a great didactic presenter, feel free to nominate them too. We also deeply value your case presentations. I think that's where we learn the most, ability to be able to apply some of the more academic or didactic knowledge to real cases that resonate with all of our clinical practices. Allison's your contact for that, or Nancy or I. We are accredited for CME through the University of Washington. Be sure to claim whatever is commensurate with your participation. No financial disclosures or any other relevant relationships. There's a significant mitigation process whenever that does occur. And as always, we welcome your feedback if you perceive otherwise. Just want to revisit that. Same is true for nursing. And then here we are across the state. You will perhaps notice where you are on this map. Sit here today. And again, if you'd be so kind as to enter your name, your role, clinic name, particularly if this is your first time here. And we're always happy to add you to the mailing lists. Here's our fantastically talented hub team, representing a variety of organizations. And this continues to be one of the things I am most pleased with this project, is that it is cross-institutional and really a function of the Dementia Action Collaborative, which will be undertaking a revision of our state plan starting next week. So lots to stay tuned about there. And with that, I may turn it over to our fantastic colleague, Dr. Whitney Carlson, who is Medical Director of the Geriatric Psychiatry Services here at Clinic at Harborview at the University of Washington, who will be speaking about when medications aren't wanted or don't work, manage geriatric depression and demotivation. So with that, I will turn it over to you, Dr. Carlson. You are muted still. There you go.
I'm always so careful to mute and then I forget to unmute myself. Okay. All right. So yeah, this is a topic that's sort of near and dear to my heart because it's just so common. I was coming from a nursing home today, and even though most of my patients weren't geriatric, 3 out of 3 were apathetic, having motivational problems. So mainly because of their neurologic issues that they're having. So it's just such a pervasive problem, and it's probably one of the hardest things to deal with for clinicians and families. Patients plus minus depends on their perspective, which we're going to talk about. So I imagine we've all seen people sitting like this that are older adults, and you kind of sit and wonder, are they thinking? Are they staring blankly out the window? What is going on in their head? Why aren't they doing anything? It's a really common presentation, especially in long-term care, but lots of other settings too, if you look around. So is this depression? Is it apathy or demotivation would be another word, or both? I put these pictures up just to sort of tell you how I try to look at the difference between depression and apathy as an entity by itself. So not everybody who's depressed looks like this poor woman that's like clearly distressed. But it's to point out the pretty significant difference between apathy alone and depression, which is that there's some emotion for the person with depression that you're looking for, rather than just not doing anything, because that's a really important diagnostic criteria for depression is the emotional part. So it just kind of gives you a visual of the other people are just kind of sitting there. I think Merriam-Webster dictionary definition of apathy, which also includes this lack of feeling or emotion or impassiveness, or lack of interest or concern, which are two pretty key elements of apathy or demotivation. This is a very significant problem, apathy and demotivation syndrome. It's really common in neuropsychiatric disorders. It's 55% or more possibly in Alzheimer's, and it's even more common in some other subsets of dementia, like frontotemporal dementia. So if you have an NPI or a neuropsychiatric inventory, you'll see that this is a pretty prominent symptom that people point out that they're often concerned about. And it's also prominent not just in dementia, but all neurocognitive disorders. The people I saw today were anoxic brain injury, a person who had been shot in the head, and the other person had depression history, but wasn't currently depressed, but pretty apathetic. So it runs the gamut, and so it's very pervasive. It often causes a lot of caregiver distress because caregivers are usually trying to get their family members to do things, either that doctors are wanting them to do or that the caregiver themselves wants to do. It can really limit their lives a lot when this person isn't doing what they hope they're going to do. The person can have a decreased quality of life based on just not being in the world, or having physical or medical problems because of things that they aren't able to participate in. They definitely have more medical issues if they're not active. They can have, weight loss. They can have contractures sometimes if they're not moving or participating in therapy. And they definitely have a worsening decline and often end up institutionalized much earlier than maybe they would have if they didn't have this syndrome. There are subtypes of apathy that you'll find in the literature. And I think the long view is that hopefully if we identify subsets that we might have better interventions if we can figure out what works. So there's behavioral apathy, there's cognitive apathy, and then emotional apathy. Apathy is often misunderstood or ignored. So in long-term care, if somebody's not screaming and calling on the call light every 5 seconds, it often just gets ignored. It's like, well, people assume that's like normal. At times, depending on who they are, or it can be misinterpreted as depression. And sometimes it is depression with apathy, but a lot of times it's not. There's no emotional element of depression to it. So, and I point out the parallels to hyperactive versus hypoactive delirium because I also work on the inpatient consult service. And so, you're going to get called in psychiatry for hyperactive delirium about immediately because they're pulling lines, they're all over the place. And then you'll get a depression consult, which is not as urgent from their team's point of view for hypoactive delirium. So it's similar, there's active, maybe they're doing things that are disruptive to the environment, or they're sitting around doing nothing, but it's still a concern. They're still not doing what they should be doing. So apathy can be associated with weight loss, social withdrawal, just not engaging at all, with caregivers, with the environment, and then a decline in their overall health. And it's often misinterpreted by many people as volitional refusal, like if there's some purpose why they're doing this. You know, you must be doing it to make me angry, or I've done something wrong to make you upset, so you're doing this to make my life miserable. Or it can be from people think it's depression. These are just, I think, what the key points between apathy versus depression, and then the overlap. So people have apathy syndrome without depression often have affective flattening or indifference. They just don't react to anything. It could be happy, it could be sad, nothing. It's just like meh. There's nothing to it. They don't smile a lot. They don't really engage. They don't look anxious. They're not crying or talking about feeling sad. They just are a bump on the log. That's what they kind of remind you of. Not a lot of movement or hand gestures or nonverbal communications, just sitting. Decreased goal-directed behavior and thoughts can be in both. They don't usually want either one. People with depression or people who have apathy want to pursue anything that's rewarding. Usually the people with depression, it's just the thought of it is like too much energy to do. Like I might want to do that, but it's just too much work. So it's less tied to just not wanting to, like I don't want to engage, and more like I just can't get up the energy to do it. And anhedonia is somewhat similar, but that's not really seen in apathy at all, because they're not enjoying anything either way. They just don't engage at all. People with depression do still consider social relationships important and want to interact, but they just don't have it in them to pursue it. It's just, and it makes them sad. You'll hear them talk about that. They're sad, they feel guilty, they feel like they should be doing it. You will not hear should or would or anything from people who have apathy syndrome. It doesn't concern them. And then this is just another way of comparing. So for depression, apathy can coexist with it. And it's often the part that's left over when we treat depression relatively well, but there's just not enough energy or motivation to do things. Apathy often just exists on its own. Depression, they'll have anhedonia, meaning they can't enjoy things that maybe they used to. And apathetic patients usually just have a global lack of interest or motivation. It doesn't matter what it is. Even something they can enjoy, something neutral, nothing. People with depression often express guilt or sadness or anxiety about their not doing. They will talk about that, even when it coexists with apathy. They can express suicidal ideation. People with apathy alone do not do that. They appear indifferent. They don't really have appreciation for how that impacts other people. It just doesn't, it's like they don't even have an awareness of how they're being with other people at all. People with depression are sad. They're distressed usually. They may not say it unless you tell them, but sometimes they do. You'll hear the content of what they're talking about is negative or sad or regretful. People with apathy just don't have much emotional reactivity at all, no matter what. It could be, hey, Julie's getting married. Oh, hey, Joe just died. Oh, there's nothing to it. It's just, or maybe no reaction at all. Depression may respond to antidepressants. Sometimes it does, sometimes not fully. Apathy can actually be worsened by some antidepressants, particularly SSRIs. So a pretty common situation is someone gets labeled with depression who has apathy, and then the dose keeps going up on an SSRI, and it gets worse. Like whatever they were doing, if at all, becomes even worse. So particularly as a syndrome known with SSRIs. So it's just why it's important to identify what it actually you're treating. Both depression and apathy are common in neurocognitive disorders, and including MCI. Both can present with lack of energy and cognitive concerns. So the patient that you have come in, regardless of depression or apathy, may come in and say, I'm having memory problems, I have no energy. Both of them can say that, and it could be part of both of these syndromes. Both of these can increase caregiver burden and lead to more rapid physical and cognitive decline. So they're both important to identify. They're both important to treat where you can. The apathy is much harder to treat. This is just to point out some environmental things that may play a role, both in depression, but also apathy. And I've witnessed many of these things. I'm sure you guys have too, when you've seen dyads of a patient and a caregiver, for example. There's an element of learned helplessness, which is kind of a well-known principle for depression. It's I don't know how much people have studied psychology, but there was the idea was like a rat running through like a maze or a mouse and kept getting shocked, and eventually they just lay down and take it. They couldn't avoid it, so they would just take it. So it's somewhat similar for people who are maybe trying to do what they've always done, but because of their cognitive abilities or their energy level, or they can't do it the way they used to, and people take over those tasks for them because it's not getting done at all, or they might criticize or try to help. Oh, don't put the dish in that way, it goes in this way, versus the other person's just trying to do something to help. And then some people just stop doing it. They just say, well, what's the point, because I can't do it right anyway. And so, but the person with depression will have emotions about that. The person with apathy will be like, take it or leave it. Like difficulty with language. So when people start having word finding, or they can't come up with, they can't process quickly information, which can also happen with depression, this sort of slowed thinking. They stop talking. People start talking for you. They start interrupting you because you're taking too long to answer the question. And then you just say, well, what's the point of talking? And this is a really big pet peeve of mine. So I've had a number of people come in the office, and the family will start talking for the patient before I even have a chance to talk to the patient at all myself. So I like to say, this is my patient. The family is too, but my primary focus at the beginning is engaging and trying to make a connection with the patient themselves, because they often get ignored, or it's just become the way things develop. It's just become that way, and then people may not have an awareness at all that they're doing it. Alexithymia is when people may not be able to describe their emotional experience. It can be because of word finding or language problems. It can be because people are just it's not in their natural way to be able to describe what they're feeling. So a lot of people who are somaticizers, they have alexithymia. They just can't put into words what their mind is feeling. So they put it into a physical thing that they can describe. But if people misunderstand that and they're really not getting what they need, like they might come in with pain, but what they really want is someone to like give them a hug or the personal touch of some kind, or just listen, they don't get what they need. And so then they just stop trying to talk with you about what they feel. And then just, I think the backstory for a lot of people with cognitive disorders is this fear of not knowing who I can be if I can't do what I used to do. Like, who am I now, or what worth am I? People with depression will talk about that. They'll feel really guilty. They can't do anything. What am I supposed to be doing with my life? I'm such a burden. And so that can kind of overlay the story of these people too. And this is just, I think I found it on a dementia caregiver website, but around the dynamics of criticism or telling people they're not doing a good job or you're not doing it right. So this person said, when you're frustrated with me because of things I can't do, just imagine how frustrated I must be because I'm no longer able to do them. So just a good reminder to put ourselves in someone else's shoes of what they might be feeling, or remind other people to do that. I talked a little bit about the SSRIs in particular for depression. So if they have depression with apathy, it will probably help the depression part. They might start eating better or sleeping better, or not talking about suicide, or feeling a little more hopeful. But they'll say, I just can't do anything. I can't get anything done. I just blah. I'm happier, but I'm not doing the things I want to do. So if it's apathy alone, they won't talk that way. They won't be telling you they're sad or depressed or anything like that. And you're trying to get them to go. You're trying to just give them something that will get them going. but you're not treating what the underlying problem is. So for depression, sometimes we have to augment with other things. If, say, we use an SSRI and the part is not improving, then we might augment with like Wellbutrin, which is a dopamine agent, and then that sometimes gives people energy, and it also helps resolve the rest of their depression. But in older adults, of course, we want to try to avoid polypharmacy where we can. So most of the people that I see have already been on SSRIs, and either they don't work, they stopped working. So I don't really have this problem because I just leave those off my list. So I do end up with things like norepinephrine agents like venlafaxine or duloxetine, maybe Wellbutrin, mirtazapine. So by definition, sometimes they get better just from that, and it may help their apathy depending on what I choose. So bupropion and methylphenidate can help the activation part, the energy part. I've had a number of people that, again, they do pretty well with the depression part, but they aren't doing what they want to do. And I will add at methylphenidate for some people, and they actually do really well. Even just a teeny little dose once a day gets them going and helps them get over the hump of the last part of their depression syndrome. But for people with apathy, potentially these could be helpful too. And I'm going to talk a little bit about a recent study that showed methylphenidate helpful in apathy with dementia. And then acetylcholinesterase inhibitors may help apathy in some dementias. So sometimes, a lot of my trainees will ask, like, what are you looking for? Because it's not like a memory medicine per se. But I feel like sometimes when you start somebody with mild cognitive impairment or early dementia with acetylcholinesterase inhibitor, people will talk about them being able to engage more or, have more language ability, like more back and forth. And I feel like that's part of overcoming a little bit of the apathy that they have. Like it may help them engage a bit better. So I think it's one reason to consider, those agents earlier than later for where it's appropriate. I just happened to come across this. I was like, surely someone must have looked at this, and surely they have. This is a recent publication from last year in JAMA Neurology about a methylphenidate trial, and they had done a pilot study already with a smaller group. This was for people with Alzheimer's. It's a randomized controlled trial. It ran for 6 months, and they were just looking at improvement in apathy in different categories of behavior. They gave 20 milligrams a day. I don't remember if it was all at once or split. I think it was split dosing, like 10 twice a day. And they did show improvements in apathy scores within the first 100 days, but there wasn't further improvement after that. But there was not a significant improvement in their participation in ADLs, which is one of the things that's the most hard, because that's kind of what you want them to be participating, doing stuff for themselves, because that's that's what you're hoping they're going to do, so that you don't have to do it all for them or make them do it. So that's unfortunate, but at least there was some improvement in some parts of apathy, which I think is really hopeful. And then in this work group on Alzheimer's disease and other dementias, which is like a work group, kind of coming up with a consensus statement for the most effective approaches to apathy and dementia. And they looked at the subtypes of apathy, and what they found is that the two targets that were most benefited were emotion-oriented apathy with things like reminiscence therapy or validation therapy or supportive therapy, and then stimulation-oriented with just, having things to do and, exposure to structure with recreation, art therapy, music. And I think that's, in my personal experience, also true. I don't know, but I feel like sometimes a part of apathy is, I don't know if they're conscious of it or not, but they just don't feel seen. They just feel invisible. And so if you can start to get to know who they were as a person before and talk about their history, it really engages them. They can talk. I've had a number of experiences where someone just won't answer much of my questions about how they're doing now. Nothing. But you ask them about their life prior or when their kids were little, they really start to brighten, or like maybe something they taught in the past, or some job that they had, or they traveled to Asia, or they really get going. And so in some ways, I think it's just trying to remember that the person in front of you has had a lot of experiences in getting to know what those are, and then validating anything they're talking about, whether it has emotions behind it or not, is just saying, yeah, you know, it's a different situation that you're in now. You probably can't do some of those things. That sounds hard, those kind of things. And then another point I read was, you know, just like we sort of outgrow friendships sometimes, where you sort of like, well, I like that person, but they kind of do the same things. It's not very interesting anymore. I think sometimes people develop a sort of, they're used to things, or they don't, nothing, it doesn't spark their passion anymore, or their doesn't light them up anymore. So you try to get them to do the same thing. Like a perfect example is my husband's family. We always go to the zoo. I can tell you, I love zoos. I'm done with the zoo. I don't want to do it anymore. And I love animals. Like, I'd like to go see it, but you just get kind of bored. And so sometimes having some new things to do, like maybe you've always been a music person, but someone takes you to an art museum and it's suddenly like this whole new thing that you never really were exposed to. So, and then for behavior oriented or cognition oriented therapies in this particular work group, they did not feel like that really had much of an impact in apathy in particular. So just some management strategies for caregivers, for people who take care of people in long-term care settings. Setting realistic expectations and goals. You don't want to be negative that it's not going to get better, but you do want to say, like, practically, this may not improve a ton, you know, like, so that they don't have this huge expectation and then put that on the patient to be like, you have to be doing these things, because then they get in this big battle of like, you know, you're not doing it and we're going to get in trouble, or I'm upset with you. So it can be a hard balance, because you really do want to encourage them to try things so that they don't just give up, but yet at the same time, how much can actually change. I think daily routines help when people know that it's an expectation, and that kind of goes to this, when there's a routine, instead of saying, do you want to go do this? You can just say, today, you know, it's time to go out today. We always go out on Mondays. We're going out. It's time to go. So it's like an expectation without like a debate about it. Perfect is any good, meaning let people do stuff how they can do it, you know? If somebody loaded my dishwasher and it was imperfect, I'd be like thrilled, because, you know, I'm usually the one doing it. So I'm like, go ahead, that's great. I don't care how you put the knives in, it's totally fine. Let them do what they want to do. I'm a proponent. I'm not a medicine doctor, but if someone is not eating at a nursing home and they'll eat a magic cup all day long, if you give them a magic cup over and over again, give them magic cups till the end of time. They're eating some kind of calories. Yes, it's not good for people with diabetes. Yes, there are other issues, but it depends on what your quality of life or what your goals are. So don't try to make them eat pureed sweet potatoes if they won't eat them, and they'll eat something else. Expose them to new things, like just encouraging. I love the Dementia calendar. I always look there. I think I'm going to be a great older person, because I think all those things sound so fun. So I think, you know, it depends on the person, but some people just never have had an opportunity to be exposed to things. And it's good to remember that, why not try it? You know, it's worth it. Remind people that just spending time with the person without needing to do anything or accomplish anything is totally fine and may be a good goal. Just sit with them. Maybe you're just looking at the lake and you don't have to have a conversation. You're just out in nature. You don't have to go on a walk. You don't have to, you know, identify all the birds that you see, anything. You can just be with the person. Sometimes that's what matters. Movement of some kind doesn't mean go out and walk 2 miles a day, although that would be fantastic. But sometimes they're not going to do that, but maybe they'll get up and walk around your house, or they'll do some stretches in the air with you, or do some yoga poses or whatever. Just do something. And then trying to make sure their sleep is good, because when you don't have enough sleep, your energy is low, you're definitely going to not feel like doing anything. You may not be able to say it that way, but that's a priority. And this is just, it just happened to catch my eye because of the fall leaves and it's fall. But I thought it was a nice kind of statement about letting go of expectations. Like, things might have been this way before, but we can't expect them to be this way, and we have to be okay with it. So I think it's nice that the trees are okay with letting go of their leaves. And this is just to touch on the, what if depression isn't responding to meds? And this is a little bit med-based, but not completely. So just reconsidering things. So I have a couple questions on this case, which I'll talk to you when we get there. But reconsidering a diagnosis, like, are we missing something? You know, is somebody actually drinking a ton, and that's why they look apathetic or down, because they're just like, they're pickling their brain. And you know, people think that someone in assisted living doesn't drink because they're in assisted living. And you know, there are enablers that bring alcohol in, and some assisted livings are right by a Safeway and they still drink, but we don't know that because we're not seeing them. So just remembering to ask. The cohort coming was also from the 60s, so there's a lot of other stuff going on as well. And then access to that kind of stuff is more and more available, unfortunately. So just rethinking what's not getting better and why. Are we treating something that's not just depression? Is it bipolar disorder? Do they have a trauma history that maybe they're having horrible dreams and they're not sleeping well, but they're not talking about it? And then always medical issues. Did we miss sleep apnea, which is a huge one for like lack of improvement in depression, sleep problems, cognitive problems? Or are we missing an underlying cognitive disorder? You know, really what's going on is they're not able to do the things they used to do, and that's making their depression worse. If we don't identify the right syndrome to treat, then it feels like a failure, and we feel like we're treating, there's no point. And so sometimes just reassessing that regularly is a good idea. Therapy, has therapy been tried? A lot of older people would rather do therapy than take meds because of all the complications. The problem is actually accessing therapy, which I know well is a huge problem. But with virtual stuff, there's actually a lot more access to that, as long as the person that you're treating can do the telemedicine kind of part, because there's a lot more options for that now. And then are they actually taking what you're giving them? Because sometimes people don't tell you because they don't want to be a bad patient. So they'll just say, oh, I'm feeling good, doc, it's fine. But if I've asked, I've just, you know, are you taking the medicine? Some people tell me they just kind of don't feel like it, or it's not helping, so they just stop it. And that's really opened up a lot of options where people say, well, I just couldn't afford it, or I took it for 2 weeks and it wasn't helping. And then I realized I didn't do a good job with education, that it was going to take longer than 2 weeks. And then have you considered augmentation strategies, or are you giving them enough medicine? Sometimes that's the issue. But the therapy piece, I definitely want to point out, because there's often a lot of psychosocial issues or other things that are sustaining a depression that meds are never going to help. And I think unless we address those, that's a big issue. And then there are some non-pharmacologic things that we use in psychiatry a lot, which are ECT, like shock treatments, and then TMS, or transcranial magnetic stimulation, not available as widely. And ECT is not available widely either, but TMS actually is being looked at for apathy by itself as a treatment because of its deep brain stimulation. And so I think that's an interesting idea that could become a lot more prominent in treatment. So, and this is just to remember that I think there's a lot of pull sometimes to go back to the way things were. And, you know, I just want it to be the way it was. And you just really can't do that a lot of the time. You have to be mindful, be where you are, and then try to change the ending. So I can't do that stuff, but let's see what opportunities there are for going forward and making things even better, despite apathy or depression or dementia. Just to constantly provide people with hope that things can be good no matter what. So I like C.S. Lewis. He has a lot of good quotes. And then these are just some of the references. I listed the JAMA article for the methylphenidate trial, but these are a couple other the references I used for this talk too. So in case you want those. And that's all I got.
Whitney, thank you so much for this wonderful presentation. Boy, it's as pervasive as it is difficult to treat. So I think we've got some time for some questions. Feel free to unmute and ask away.
Well, Dr. Carlson, you mentioned that ECT is not easily accessible either, but what would the process would be for primary care to pursue that, or maybe suggest that to a patient? Have you seen it done in primary care? I mean, obviously we don't administer or maybe make the referral, but who is making that referral?
Well, usually the people who do ECT will want to have had an evaluation, either of their own, obviously, like they're not just, you don't send them in for ECT without someone evaluating it. So whether it's a psychiatrist that sees them that doesn't do ECT, but can comment on that and then make a referral, or you're referring them to a psychiatrist who does evaluations for that. So for example, Swedish has a very robust TMS and ECT program. So a lot of the primary care doctors might be more familiar with that, but they do consultations. They'll say yes or no for that. Harborview does. Our program at the moment is quite small. A lot of hospitals will do it, but they, you'd have to kind of know somebody from psychiatry. So if they have an inpatient unit, they may do ECT. I'm not really that familiar with around the state. I do know there's no one in Idaho that does it. And there's I was just talking to our ECT doctor. It's really limited. And so we're trying to build, people learning about that. But primary care doctors can refer to someone who could do that diagnostic evaluation and kind of give their ideas about why. I usually tell patients, you're not getting better with meds. I'd like you to see someone who can offer some other kinds of treatments. You don't have to commit to anything. They'll explain it a little bit better than maybe I'm able to. It might sound scary, but it's really effective. It's worth a try if you're feeling so bad.
This is Franja. I've got a question. I'm wondering, in like facility type settings, these kinds of interventions, first of all, they make really good sense, right? That's kind of how you treat your children, treat your loved ones. Like these things just kind of resonate. But have you found that just getting one caregiver on board is enough, or does it really have to be like a cultural shift? Like everybody needs to be doing this for it to work?
I don't think everyone has to be on board. I do think sometimes for certain patients, I've had a couple people that will buy into it, and I'll strongly suggest that those are the people that work with the patient. Because you're never going to get complete buy-in from everybody. Some people just don't believe in it, or it's just not their nature. But I think education goes a long way. I think a lot of people in long-term care that are safe aides, for example, they want to do better, but they just don't know they don't have the education for it. They really aren't taught much about dementia, believe it or not. And so how to approach people. And so when George, one of my case managers, and I have done some education, and we went to the hospice where Mimi is. I saw her on here. Just giving people information about things to try really helps them at least have a place to start, and then they can come to you and say, well, it's not working, or we can't problem solve it. So I think getting one or two people, or even like the director of nursing or somebody else that can do broader education, from you, and reinforce that as a community goal is helpful.
Thanks.
Very good. And I see Dr. Martinez's hand up.
Yeah, wanted to ask about ketamine. Do you have any information about that or any opinions about that?
It's interesting you asked that. We were just talking about here. We don't actually give it here at Harborview. It's not because we just don't have the monitoring that needs to be done afterwards. So I haven't had much experience with it myself at all. There are some people who believe highly, and especially for treatment refractory kind of depression. I don't know anything about that in apathy alone. Like if there's any information about that, I haven't read about that at all. I believe Swedish's Neuropsychiatric Treatment Center does do ketamine as well. And there are actually freestanding ketamine clinics. But people are frequently coming into us asking why we're not doing it. We just don't have the facilities really at the moment, but we will probably be doing that. So I don't really have a great opinion about it in terms of like dementia related depression or geriatric depression. I'm usually scared about anything new for older people because it hasn't been actually tested in old people at all. So I usually reserve judgment until I see what happens. So that's my off the record point of view for old people.
Excellent. Any other last minute questions before we rotate to the case? which is also an opportunity to bring up other questions and have a larger discussion. Let's see, I see a couple things in the chat. Yes, the slides are part of the recording, so yep, those are available. And then let's see, Kristen is saying the Eden Alternative has some great philosophical literature about this issue. Next.
I love the Eden, initiative. It's excellent.
Great. All right. Yeah, thank you. Resources always appreciated. So thank you for adding those. All right. Well, if no other questions, and again, feel free to bring things up during the case discussion. I am going to go ahead and share my screen and turn it over to Julie Holgado in the lovely Tri-Cities with today's case. And Julie, I'm happy to click through the slides.
Okay, thank you.
We imported your case into the slides, and it may mesh with how you want to deliver this. It may not, but let me know what you want me to do.
Okay, thank you. I did choose this presentation because the very first time I saw this patient, I assumed I would be bringing her for a case study because of how complicated her medications and her presentation prior to establishment were. She's a 75-year-old female college graduate homemaker. She was self-referred or possibly referred by her primary care to the senior clinic. I don't see an actual referral in our system, but her spouse called, made an appointment, and said that he was told she has dementia, so now she has to go to the senior clinic by her primary care. Her main complaint on her initial presentation was that she had just worsening depression since COVID started. And then she was also unable to use the computer or manage finances or find the motivation to do housework, which is was very distressing to her. So she attributed that to her depression. But then there was also the question whether her previously established mild cognitive impairment was also worsening to dementia. So she has a past medical history of essential tremor for 30 years, polyneuropathy for 30 years, major depression disorder for about 40 years. She states it started after her children grew up and left the home. And then she has been on antidepressants and seen a neurologist most of that time. Not a significant social history for any alcohol use or drug use. And, she's married and pretty stable home life. So her medication list kind of alarmed me at first. Didn't quite know what to do. When she initially presented, she was on Rexulti instead of Abilify. We made a change from the Rexulti to Abilify because of financial concerns. She was getting, she was getting samples on the Rexulti, and then her psychiatrist kind of left her. So, and initially on presentation, I thought that I was just going to manage her cognitive concerns. And then when her psychiatrist left, I was left to prescribe the other medications too. So this was, I started the Aricept. I think I'll probably say that her cognitive impairment previously was somewhat mild with like a WACE, the Washington cognitive evaluation being 88 out of 100 and pretty stable over the last 3 or 4 years. And then on her presentation in March, she had a MoCA of 20 out of 30. So it did appear that her cognition was worsening, with also her report of decreased ability to perform cognitive functions. So based on that, I did open the conversation about dementia and said, let's try Aricept. And we started her on it without a lot of report of improvement. I've seen her over the last few months, and the frustration on her part and on my part is that really despite we did lab work with really all essentially normal back in March. She did have a urinary tract infection in July, and we treated that without any change. No change in mentation with it and no change after it. It was actually very simple symptomatic UTI. So we have this frustration where every time she comes to the office, she has pretty much the same report of feeling that her depression is overwhelming, is not well controlled. She's taken all these medications, and she sees her housework as not, as overwhelming too, and she is frustrated with her inability to do what she used to do. She has some resistance to lowering medications, such as at one point I did. We've talked a couple times about reducing her lorazepam use, and she is very resistant to lowering it. And then she has been told to never stop the Lamictal, which I have no idea if the Lamictal is doing anything for her, and I'm not feeling specialized enough to know whether it's doing something beneficial, just adding side effects, or whether it's doing any harm. So that was a question on this this patient, is just this mess of medication she's on. And my question would be just how do I make changes? I'll say that, I think medications are that target which seemed the easiest to manipulate, to make changes and hope for effect, because it's something measurable versus we've talked about physical therapy, and she took the referral and she's gone a couple times, and then we talked about maybe getting more caregiver support in the home to maybe alleviate some of the overwhelm she has with her housework. And the husband and her are somewhat resistant to that. The husband wants to let her try to do well, I think they're both in a little denial that she's struggling more with her functional abilities, because even when I ask him to maybe start doing the financial portion of their household, he's a little resistant to taking that over as well. So they're both overwhelmed with the changes that are going on with her, and they want to talk about her depression, but she's on kind of max doses for all her antidepressants, and they're not working. So that's, again, why I kind of bring her this talk, is that the medications don't seem to be working, and what is the next step? Her previous primary care provider had written in a note that maybe ECT was an option. I just have never, discussed that with her or referred a patient to that. And I don't know how it would work or whether it's contraindicated in the cognitive impairment. So I do know that I would like to reduce polypharmacy, and want to know what targets I can do to reduce her side effects while still alleviating symptoms. Discuss ways to reduce the overwhelm the patient is experiencing at the loss of her cognitive abilities. And the question of is this demotivation? I would say that after watching this talk, I would say that she has a lot of emotion about what she's not able to do. So I don't think it's the apathy syndrome as much as depression and frustration at still being very cognitively intact and knowing that she doesn't have the same abilities that she did a couple of years ago. And then third question would be, when will I know if the Aricept is helping her symptoms? If she comes in every time and states that it's not helping, how do I persist in prescribing it and monitoring it? It's not causing her any ill effects, so it's not causing harm. It just makes me question, is there something I can be monitoring more to say this is helping her in some way?
Thank you, Julie. This is a great case, and again, perfect timing. So appreciate you bringing it forward today. And I am sure that many of our hub team members have ideas about deprescribing and reducing polypharmacy, including Trang, and I saw Barack with some nonverbals there. She commented on some things. And I'm absolutely sure Dr. Carlson has some great suggestions too. Before we jump to suggestions though, and I'm curious from our community, are there any other questions about this case, things you want to know, knowing that it may have been completed or not? Any other parts of the workup that would be interesting to you?
Did you has there been any like actual measurement of depression, like PHQ-9 or anything?
You know, that's a good question. I feel embarrassed to say that she's a little difficult to tie down on. So we didn't do the, let me double check. We didn't do the PHQ-9 in our appointments. Her, and plus I feel embarrassed because when she presented, she was talking about, you know, wanting to be established for dementia. I assume she's getting management of depression with someone else. And then I kind of resumed the role of managing depression. So her PHQ-9 and GAD score 2 years ago were actually fairly low, but in her actual notes from her providers, they would mention the same exact same things that she's saying now. It's just that depression was like a constant battle, that she didn't get to things, and like her prior PCP, it sounded like he almost fired her for being just so frustratingly not improving. It's so it sounds like the notes that I'm reading are very similar to what I'm seeing too, is just she'll come in every time and say kind of the same story, that nothing's improving and she's depressed and frustrated. It's a good question.
Yeah, and I didn't mean any criticism. I'm just pointing out the whole thing with the whole apathy versus depression. Sometimes people will say I'm depressed, but actually what they're experiencing is reaction to their lack of abilities from other things. And so that's my suspicion.
In which case, if she had a kind of low score, despite saying that she's depressed on like the PHQ-9, then one would say this is more frustration, not maybe the depression, or vice versa if it's high. Sorry.
I mean, not always. It's just one screen. And frankly, some people with cognitive impairment, they can't really track 2 weeks worth anyway. So I question the validity. It sometimes does give you some insight into like some of the sub questions give you more information, because there are questions on there that make you think apathy more than depression, versus like low mood, for example. So yeah.
Excellent point. Franja.
I am curious to know if she is able to speak to the things that she's able to do that she enjoys.
Yeah, she does really enjoy she was volunteering prior to COVID. She really enjoys her volunteer work, and it sounds like there is some hope for her to return to volunteer work. She used to volunteer at the hospital and greet, and so that is something she does really enjoy.
Which I'm guessing has been gone during COVID.
Yeah.
The counterbalance.
Yeah.
Okay. And my other question is it only the spouse that's involved? Are there any children?
It's a good question. It has just been the spouse coming to her appointments, and I see a daughter listed. They don't really talk about the daughter. So yes, it's just been the spouse so far.
Yeah, just interesting that he's really hesitant to take anything on or partner with her to shoulder some of that responsibility. So just curious.
Yeah, I do find that interesting, especially since they kind of self-referred. This case is a question to me, because it does feel like I don't quite know if it was just dementia, then we could get on the track of let's have the spouse take a little more, responsibility for like the financial management of the home, and let's, set up some caregiving, and let's, just make the home safe, and let's start to prescribe. This element of depression just seems to add this real confusion to it. And then there's the denial of her cognition being impaired, even though she has established cognitive impairment, it hasn't been so severe. And this is just the MOCA of the 20 of 30 is just one reading. So I hate to, make it too dementia too hard and fast a diagnosis, except that I feel like it's better to talk about it and set these things up rather than to not acknowledge cognitive decline. So it's.
Did she have a religious community or anything? Any kind of?
They've not talked about any community. They don't go to church or have any sort of other social. They actually, in multiple notes, they have actually a very isolated kind of life, that they just stay at home. Yeah.
This is a really tough situation, and I can't imagine having to try to unpack that in a standard office visit. So kudos to you.
I had a lot more hope at the very start of the relationship, thinking that, well, maybe we would kind of get the ball rolling with a few, referrals to therapy, and then we'd get kind of the ball rolling with some Aricept. And, now you're here at the senior clinic, you're ready to kind of just start I think she's really stuck in the can't let go of what she used to do and can't go forward to what she kind of needs to do next.
Yeah.
So maybe a few more visits, and then things will start to get rolling. But I was just, what could just press that balance of, tip the balance of like, okay, now we're ready to just accept where she's at, accept what she can and cannot do. And I don't know, clean out her, she's so overwhelmed about her computer area that she says that paper is piling up. I'm just thinking, well, anyone would be distressed by that. Someone has to go in and just clean that computer area up and just say, you don't have to worry about that anymore. Or maybe you can, but I don't, if anyone has any ways to help that process along, it'd be helpful.
I'm actually wondering a bit about her spouse's cognition. That's what I'm one of my mentors, like there would be a presenting patient, and then there would be, why doesn't this other person have any appreciation for this problem? And then there would be children, and then we'd start to point out that this pair is not doing well. And so someone saying, is there any children involved, in the fact that she was so depressed after her kids left, and then they're not talking about the kids at all, is very curious to me. And that, it's not going to solve this problem. And I have lots to say about the medicines too, which I can get into later, but I didn't want to take over with that discussion, because I think there's a lot to this. There's a loss of role, which she clearly had a loss of a role when her kids left. And then now she's not doing her housework, so she's probably not feeling very good about herself. So there's that part of the depression, I think, is clear. But what you're experiencing, I think, and they're experiencing, is this loss of hope. Like there's nothing, that I'm not getting better. And I think the setting of the expectations of this part of this is maybe not going to get better the way you want it to. I wouldn't just say that, but I mean, it's a new normal of, there may still be some things to do with the depression. I would highly, highly recommend she get into counseling. I think she needs that if there's any options for that.
Great insight. I think actually you're absolutely right about that's probably the next target I could make, is just getting more family involved, seeing that the making assumptions about the spouse, that he is the person who's going to start shouldering the burden, or I don't want to say burden, shouldering more responsibility. Maybe it is about time to start saying, who else in your life can start helping, and getting more, maybe it seems like he's overwhelmed too. Yeah.
Julie, I have just two quick questions. One, is her hearing okay?
Yes, her hearing's good.
All right. And has she had any kind of imaging?
Yes, she has had CAT scan imaging a couple times, and nothing really significant on CAT scan, just mild white matter loss. And MRI in the head in the past, get off the top of me, it would have been a remote past for MRI of the head. Where is one?
Well, how about we transition into some recommendations? Our community, I'm sure, is chomping at the bit to provide some input here. Would it be helpful if I put the medications back up so people can take a look at that? Let me do that.
Yeah, thank you. And then I know that the frequencies aren't there, but she is pretty much on max doses of those antidepressants, Wellbutrin's 300 milligrams once a day. This, oh, there we go. They've got the doses there.
There are just so many screens of this.
Yes. Okay. Boy. Well, for meds, I mean, maybe other people have some ideas. The most harmful is the one you already identified, which was lorazepam. But if she's wedded to it, I wouldn't try to mess with that. I would try to work on some other things. I think there's potentially some opportunities to see if she'd be willing to transition to mirtazapine as her primary antidepressant, because it's got a different profile than just an SSRI does. And I've had good luck with mirtazapine. The problem is when she go up, she might lose the sedation for sleep, but I wouldn't tell her that. So it might be the kind of thing where you just start cutting her off the citalopram, which is over max doses for her age anyway. It has a potential for QTC prolongation, although she doesn't have any cardiac issues, so it's probably not as much an issue. But it's not helping. So you could just maybe talk to her about trying a different antidepressant at a better dose. That might be one idea. I'm not sure. The lamotrigine is very curious to me, because to me, if she saw a psychiatrist, it means that they might have thought that she had something other than just depression, like bipolar disorder or something like that. But it's not a very good depression medicine for people with bipolar disorder. It's kind of something that gets thrown in there when somebody isn't getting better, and we just say, like, I don't know, maybe I'm missing the diagnosis. Let's just add lamotrigine. So I'm not sure what the "don't come off of this ever" is about, because I'm not sure what that means. And the fact that she can't really give me more information, or the spouse can't, that makes me, I'm interested in that too. It's not going to be the most harmful. The other one I would try to get her off of besides Celexa would be the antipsychotic. Those are cognitive issues. And I know the theory that it was try to boost, it's like depression hurts, let's add it, or boost the effect. If you're not getting better from your antidepressant, add this. It's expensive. It's potentially harmful. She has a tremor already, so she might get extrapyramidal symptoms. She's probably not, and it's just not adding anything either. So if I had to pick, that's the way I would do it. There's nothing going to really be harmful, but it's just way too many medicines. And what it means to me is someone was just not seeing anybody getting better, and just kept adding and adding and adding. And either she was resistant to taking stuff away, or they were resistant to letting it go as the psychiatrist. I don't know, but that's sort of the direction I would go.
Thank you so much about the and the insight in the antipsychotic, that it's like that terminology of like it's not adding, I think is probably the main reason it's not adding and add so much risk. And the tremor is a highly motivating reason to get off that one. So that might be one she's more open to. It's one of the last ones to be added from her psychiatrist, so I think she'd be more willing to get off that one. And the mirtazapine, so I have seen some dosing of mirtazapine up to like 45 milligrams. I mean, I would assume 30 is the max dose, but I've seen people prescribe even higher doses than that. Is there benefit to even higher than? I mean, she's on.
If they're responding to the lower. The only reason to do it is if you were seeing some response at the middle dose, but it wasn't quite getting it all the way. If you saw some early help, but you'd waited a while on that dose, but there was still some residual, then I would go up to 45. That would be me.
Okay. And then that mirtazapine could actually replace the citalopram in the sense that I know they're not exactly the same, but the combination of the two of them, they're not really there's no added benefit to being on both the SSRI and the mirtazapine. I'm sorry.
No, it might put her at risk for serotonin syndrome too.
Yes.
So I would start dropping the citalopram, pretty quickly. Not, have it for sure, and then you can go up on the mirtazapine at the same time probably, and then try to get rid of the rest of the citalopram, and then see what things look like. And then I don't know in which order you want to do things. I would probably raise the mirtazapine and try to drop the antipsychotic first. Yeah.
Okay, thank you.
Barack, I see your hand up.
Yeah, I mean, I'm just feeling like the intense difficulty of what it must be like to be in the exam room with her, and how frustrated she is, and how frustrating it feels to take care of her. And I guess the thing that is, like, I think you've identified it in the case study, is that she is like such an important first step, is like, what do you think is the thing that, like, I really can help you with the most, and that really kind of engaging her, and sort of really getting her to talk about her frustration with her cognition as the thing to get on the table first, and then here are the things that I think I can help you with the most to sort of reach that goal. And I'm really worried that you out of frustration, doctors have just put you on a lot of sort of medicine after medicine in a sort of valiant effort to find something that works, and that you've ended up sort of accumulating a lot of medicines that are ending up doing you more harm than good. And that if we're really wanting, if the health of your brain is the thing that you're the most sort of concerned about, then here's the thing that I would recommend doing. And I would for sure try to take the antipsychotic away first, and I mean, it's just, we all know just how often that is something that people sort of reach to in the hopes of maybe it can help, sort of, but then especially like at this dose, it ends up being so much more sedating than it really does end up being helpful in any way. And that if you compound the antipsychotic with the lorazepam, with the sedation of the mirtazapine, like oh my goodness, like anybody's brain would, and I would just like say to her, like, the combination of these medicines is enough to make anybody's brain sort of not work well. And I want to help your brain to work well. And I really do think that taking away one of these medicines at a time really might help you a lot. And that would be the one that I would start with.
Thank you. I like that. Thank
Yeah,
you.
Barack, thank you for that. Because I guess as I look at this case, I wonder how confident are we that she really has dementia, right? I don't want to overinterpret the MoCA, but she got 1 out of 5 on the first encoding trial. She got 3 or 4 out of 5 on the second, and then had all 5 with the category Q. That looks more like depression than Alzheimer's disease.
Yeah, I'm starting to kind of second guess. I mean, I think sometimes when people lead with like, oh, she's seeing a neurologist, she has to, the cognitive impairment, and now, it seemed like something. Yeah, I think the whole who could think clearly with all these medications on board is a very valid point. I would be very curious to see if she is more engaged, and if we got medications lowered, if she does test better, in a different setting, different time. Yeah.
Drang, you have some thoughts?
Yes, great case, Julie. Great and very challenging case. What I find that most seniors are afraid the most, 2 things they are afraid the most are memory impairment and risk of falls. They always come in and say, I'm afraid of losing my memory and afraid of falls. So those are the things that I find that work when I try to cut down the medication, to change the medications. I target those. Okay, the benzo can impair the memory because it's the sedation. It can also increase the risk of falls. So generally, most people will willing to change. What I find is most people are willing to change. Sometimes they don't. They said, "Oh, but I've been taking it for years, and so far I haven't had any problems." And then that's when we talk about we're not gonna anything cold turkey. This is going to do it gradually. But I think if we can target that, because she's coming in for concerns of her memory, and if we can use that, stating that, like Barack said earlier, these medications can impair your memory. How about we can, we just start really low and we do it, and they do gradually. We, to them. I think most of them are willing to change. They know what the plan is. Eventually, if she's gonna get older, and then benzo's gonna get her. So one of these days, we do need to cut down her benzo because she's on it 3 times a day plus an additional half needed.
Yeah. Thank you.
That's right. Other thoughts, suggestions, input? I'm seeing Barbara's question in the chat about the potential for psychedelics or psilocybin. If anyone has any thoughts about that.
That's another area I'm not too familiar with. I don't know who actually does that, but I think that adding that before trying to clean up this list would be premature. But I think it's another speak for if we do all this and she still doesn't get better and we don't think it's dementia, then maybe a second opinion with someone who does alternate kind of treatments would help.
Yeah. And then I guess the comment was for more of the previous talk, but the didactic. But I'm wondering then, at what point does one pursue like ECT? Again, I've never referred someone, but if she's just has this resistant depression, is that something that one might refer her to Swedish for? Or Harborview, Dr. Carlson?
I'm thinking. I mean, I think you want to talk about the potential for cognitive impairment with that, because even though there's some question about this, it doesn't hurt to get an opinion. I'm not sure that that's going to help her situation right now with all these meds on board. I 100% guarantee you if she goes to see them, they're going to start whittling that down right away before they do any ECT or anything. They're just going to say, we need to clean this up a bit. Especially the benzodiazepine, because she won't be able to get ECT. They'll have to get that. Well, it's an anticonvulsant basically. So.
Well, that's interesting point. I mean, if there was that goal in the future of like, there's something that can make you possibly treat your depression, but we do need to get you off this medication. I don't know. That's just extra reason too.
Yeah. And I agree. I have the same experience with Trang's comments. If you give people like plenty of time to cut down on things themselves and kind of go with what their primary concerns are, that they're more willing to, cut back on things. And with benzos, I've had good luck with just letting them decide which dose to cut down first and, by how much, and then sit with that for a while. If there's no urgency, I think it really works pretty well.
Good. And Barbara, thanks for the clarification. I caught that in the chat late. Mimi, do you have a couple of final thoughts to send us out of here?
I do, and I know we're just about out of time, but thanks, Chris. And thank you, Julie, for presenting this case. And the discussion has been great. And I would just like to acknowledge the importance of trust in this circumstance in dealing with this patient and her husband. And I think you've been seeing them now for a number of months. And I just hear a lot of great intention about what you're doing. And I think you've taken it slow and helped to develop that trust. And particularly if you're going to be sort of deprescribing and undoing what others have done, how important that is. And I just wanted to acknowledge that in your care of this couple.
Thank you for that. Very, very well said. Well, we are at time, and what a wonderful dovetailing of an excellent didactic and an equally excellent case. Thank you all so much. And join us on the 23rd for fall prevention. And Allison has put the chat or the survey in the chat. You'll also receive it via email. But again, appreciate you all so much. Hope you have a wonderful rest of your Friday and late summer, early fall. See you next time.